Hello, my name is Dr. Claudia Reardon, and I'm a psychiatrist in the USA, specifically at the University of Wisconsin School of Medicine and Public Health. I served as co-chair of the International Olympic Committee's Workgroup on Mental Health and Elite Sport, and I'm really happy to be here joining you today to share an overview of the process that we as the workgroup went through, as well as sharing some of our overarching findings from that group. Of course, I have limited time to do this. I have 25 minutes, so I'll try hard to provide a high-yield summary of the group's initiatives and findings for you. Thanks again for joining. With that, then, the outline that I have for the coming bit of time is that I'll be starting with some background information, specifically on the work group, then really diving into the findings of the work group. So looking at the prevalence and risk factors of mental health symptoms and disorders in elite athletes, diving in then to a general approach to management, and then finally talking about some specific mental health symptoms and disorders. So in the way of background, over the years, the IOC has convened work groups on a variety of health-related topics. Many of you, I'm guessing, are aware of this. And mental health's turn finally recently came. Today, I'm largely going to be highlighting the findings of that work group, which really undertook a massive review of the world's literature on the topic. I want to be sure to point out that elite athletes, as a phrase defined by our work group, specifically includes professional, Olympic, and collegiate athletes. So for the rest of this talk, when I reference that term elite athletes, that is what I mean. So the charge of our work group really was to comb the world's literature on the topic of mental health and elite athletes, and hopefully ultimately to have that knowledge culminate in a published consensus statement in the British Journal of Sports Medicine. And fortunately, we were able to accomplish that. You can see that screenshotted here. This was published in the June 2019 issue of the BJSM. As well, it turned out that we had a variety of participants in our work group, and you can see them listed here, who had really subspecialty areas of focus and interest, whether that be post-traumatic stress disorder, substance use disorder, bipolar, psychosis, and elite athletes. And those work group members ended up leading the charge on the publication of a separate set of more than 10 papers in the same issue of the British Journal of Sports Medicine. So specifically, papers on bipolar and psychosis in elite athletes, substance use in elite athletes, etc. So, what exactly did the work group find? Starting with prevalence and risk factors of mental health symptoms and disorders in elite athletes. And I'd pose to you this question just to get you thinking, not that we're able to have interaction here because of the time difference, but, what would you say if you had to answer this question? And that is, compared to the general population, how common are mental health symptoms and disorders in elite athletes? Are elite athletes relatively spared? Are they disproportionately affected, or somewhere in the middle? Well, what we found was that it is difficult to say because there is great variety in the literature, population sampled, etc. But prospective studies report that mental health disorders occur in somewhere between 5 and 35% of elite athletes when you look over a period of up to 12 months. Now, Vincent Gutebarge, of course, as I think you all are familiar, has really led the charge in this sort of epidemiologic research, and it's really been just important, paramount in drawing attention to the fact that our athletes are not spared from this kind of suffering. And in fact, when you look at the evidence, it suggests that there are certain symptoms and disorders that are even more common in elite athletes relative to the general population, specifically eating disorders, some substance use disorders. We'll get into specifics of these things in a second. ADHD, that's attention deficit hyperactivity disorder, gambling disorder, this hidden addiction that no one thinks about, and then certain sleep disorders such as sleep apnea, for example, in athletes who tend toward higher body mass index. At the same time, there are certain symptoms and disorders that are probably at least as common as in the general population, perhaps not disproportionately more common, but at least as common, including other sleep conditions such as insufficient sleep, circadian dysregulation, insomnia disorder, depression, anxiety across the spectrum of anxiety-related conditions, and post-traumatic stress disorder. When we looked at really specifically what are the sport-related risk factors for mental health symptoms and disorders in elite athletes, a number popped up. Severe musculoskeletal injuries, multiple surgeries, decreased sport performance, so slumping, choking, maladaptive perfectionism in sport, perfectionism being such a fine line, sometimes advantageous, but if things don't go right, it can really create troubles. Peak training loads, times of peak intensity of training, and then many more sport-specific risk factors in given sports for certain mental health disorders, and we'll look at that too. So now just a brief word on management and specifically looking at general approaches to management. I'm not going to get into the weeds given the time limitations in terms of, what specific medication is the number 1, 2, and 3 choice for depression in athletes, but just some general approaches. Starting with psychotherapy, because in many situations, this is the treatment of choice for high-level athletes for a number of reasons. Medications tend to have side effects. Athletes worry appropriately about side effects and their impact on performance. There are a couple of caveats that are important to keep in mind. Number one, we should recommend psychotherapy plus pharmacologic, i.e. medication therapy, when indicated, particularly for moderate to severe symptoms. If someone has a condition like bipolar disorder or a psychotic disorder, we really can't compromise that pharmacologic aspect. And additionally, we shouldn't ignore the fact that substance use problems may be present. Sometimes it's tempting to, sort of not address those problems. We don't want to offend our patient. They may have zero insight into the fact that it's an issue, and so we don't want to, push it with emphasizing the need for that. But in other words, my point of this slide here is we shouldn't compromise on full and effective evidence-based treatment if more than just routine psychotherapy is needed. I as well here have screenshotted a Stillman et al. Paper. This is one of those aforementioned subspecialty papers published in the June 2019 BJSM, and this one was specifically taking a deep dive into the topic of psychotherapy for elite athletes. What about pharmacology? So when it's needed, there are at least 4 important considerations that are relevant for elite athletes. Number 1, we really do have to think about the potential negative impact on athletic performance, so that if I'm slowing down a 100-meter dasher's time by 1/100th of a second, that could be the difference between Olympic gold and silver, between a big payday and not. It really does matter, even if that's not the kind of thing that matters to a member of the general population. Any good, sports psychiatrist really is going to have a fine understanding and appreciation of that. Number 2 and 3, these are to be distinguished, and that is we have to think about the potential therapeutic performance-enhancing effects versus the potential non-therapeutic performance-enhancing effects. We hope to have therapeutic performance-enhancing effects. That is, if someone's sport performance is being limited by the fact that they're severely anxious, panicky, or so depressed they can't even practice anymore, then hopefully treating them with a selective serotonin reuptake inhibitor, antidepressant, anti-anxiety medication is going to help them feel sufficiently better that their performance gets better in sport. And that's fair. That's acceptable. That's what we want to see. Versus the third bullet point, which is the unfair ergogenic effects. Now, in the world of psychiatry, the class of medications that really has evidence showing the potential for ergogenesis is the stimulant class of medications. Those are the medications typically used for ADHD. For that reason, they're generally prohibited by the World Anti-Doping Agency and sport-specific federations. And then finally, potential safety risks. So some medications may have seemingly minor implications for cardiac functioning. Maybe they raise blood pressure a little bit. Maybe they slightly do something like increase the QTC interval if you look at an athlete's EKG when they're taking that medication. And that may not matter to you or me if we're not high-level athletes, but it could be a potential significant safety risk in someone who's a high-level athlete pushing themselves to extreme intensities. Similarly, there are some medications such as lithium when used for bipolar disorder that really has a small, safe range of tolerability and effectiveness. In terms of looking at the blood level of that medication, the blood level has to be monitored very closely. If an athlete were to take that medication, and they do, but in those instances when they do, we really have to carefully monitor those blood levels because the littlest bit of dehydration, perhaps sweating when you're exercising in hot environments, can potentially really dangerously change those blood levels for an athlete. So with that, let's dive in then to some specific mental health symptoms and disorders. We're going to start with something that is, of great concern to a number of athletes, and that's the issue of sleep. Starting with insomnia, let's look at this 2015 study that we highlighted in our findings that looked at Olympians and their report of insomnia symptoms. Now, unfortunately, you can see somewhere between half and 3/4 of Olympians do report insomnia. This is defined as a persistent difficulty initiating or maintaining sleep at least 3 nights per week for at least 3 months. Importantly, in the context of adequate sleep opportunity and accompanied by daytime impairments. Suffice it to say, our high-level athletes, who in fact probably have higher sleep needs than non-high-level athletes, are really suffering with this. Another sleep problem, unsurprisingly, is circadian dysregulation, defined as misalignment between the individual's sleep-wake pattern and the desired pattern. So maybe they need to be up super early for their morning rowing practice, as in 4 a.m., but in fact, they're a night owl. It's really hard for them to go to bed at a decent hour. And so the fact that they have to be up at 4 a.m. is really problematic. It is a common issue in elite athletes for a number of reasons. Frequent travel across time zones can really make things difficult. That timing of sport training, as already alluded to. And then importantly, because of an athlete's chronotype, meaning the degree to which they're naturally a morning or an evening person, the timing of their training or competitions even may not line up with their personal time of peak performance. They may do better, if they have time trials or competitions in the evening, but if those competitions or time trials are happening in the morning, they're really not going to be able to show their best self in sport. So this has just been a highlighting of some of the sleep problems we see. We'll move on then to depression. And there's a big meta-analysis by Paul Gorsinski from the UK in 2017, which found that the prevalence of depressive symptoms in elite athletes equaled that in the general population. And this, unfortunately came as a surprise to a lot of people who expressed shock at the finding. Again, that sort of public perception that athletes must be relatively spared from this. They live such a great life. Look at how strong they are on the outside, etc. Clearly, they're not. There was some nuances within that general finding, both from Gorsinski and others in the field. Specifically, female athletes twice as likely to report depressive symptoms, not uncommon from the general population. And not all sports are the same. And so that there's an increasing thread in the literature showing that individual sport athletes are at greater risk than team athletes. That is just popping up time and time again. In American collegiate athletes, looking across a whole bunch of sports, track and field as an individual sport emerged as top of that list. And so we could, ask ourselves, why in the world is this the case? And I wish I could invite audience discussion here. But it's interesting to speculate, and some authors have, and people feel that, well, perhaps those athletes who are drawn to individual sports at baseline, independent of any eventual effect of sport on their mental health, tend to be more sort of anxious, internalizing, perfectionistic folks who are just more predisposed to anxiety or depression. Anyways, maybe there's something about the fact that if you lose, quote unquote, lose as an individual athlete in your sport, there's less of an ability to disperse the psychological blame for that loss. the individual athlete takes full blame. No one's at fault but me. I'm the one who lost out there. Moreover, in individual sports, there typically is one winner and the rest are quote unquote losers, versus in team sports, half of the athletes are typically winning the competition. So what about anxiety? Next big category here. So there's not nearly as much research on anxiety compared to depression, but what we found was that the rates of generalized anxiety disorder, social anxiety disorder, obsessive compulsive disorder, and panic disorder all appear to approximate those in the general population. Again, some nuanced findings, specifically subpopulations of athletes at greater risk for anxiety are those who report being dissatisfied with their career. That's no big surprise, but I think these are the important things that are important to keep in mind when you're thinking about future research protocols, when you're thinking about the individual clinician sitting with the individual athlete who is reporting things like, I'm really not happy in my sport. Female identified, younger athletes, and musculoskeletal injury. Important clinical pearls here, and that is we have to distinguish anxiety disorders that are sort of overarching and impacting the athlete in every facet of their life from sole performance anxiety, wherein the athlete is anxious only immediately before the competition or during the competition. It's not to say the latter isn't problematic, and certainly generalized anxiety disorders can coexist with performance anxiety, but there are real treatment differences in terms of if you're going to give a medication, what sort of psychotherapy you need, etc. As well as a common thing that pops up, even in my clinical practice, is referrals for what may look like anxious obsessive compulsive disorder tendencies. But if these are superstitious rituals, such as, really proscribed routines immediately before competition, you have to wear certain clothes, you have to go through certain routines of how you serve the tennis ball, etc. That's not a problem. If it's not causing dysfunction in the athlete's life, it helps them gain some semblance of control over otherwise what can feel like an unpredictable situation, and that's okay. That said, we should, take a deeper look to make sure that isn't simply part and parcel of a larger OCD package. Post-traumatic stress disorder and related disorders, again, yet another that we featured in a subspecialty review paper in that June 2019 issue of the BJSM, led up by Cindy Miller-Aaron. And what did we find? Well, athletes may encounter traumatic experiences both within and outside of sport. Within sport, these are things like sports injuries that I think historically people did not appreciate as potentially traumatic events. Because for the non-athlete, the idea of getting an injury may not seem traumatic. It may not seem all-encompassing, life-altering. But for the athlete, whose identity may be solely tied up in sport, who may now have their entire, identity, not to mention their livelihoods, taken away from them, this is a big deal. And a PTSD-like picture, if not full PTSD, can emerge. And where the evidence has particularly been focusing is musculoskeletal injury and definitely concussion as being associated with PTSD symptoms. I wanted to highlight PTSD's specific negative impact on performance because it's so interesting and intuitive how this could happen. And there is, in fact, some research on it. So the athlete who has PTSD from a sport-related injury may end up avoiding rehab or other, exercises or sports circumstances that remind them of the traumatic injury. And if they can't get back out on the court, on the practice field, etc., because that's where the injury happened, that's obviously going to have, dire implications for their ability to get back into sport. They may have this inhibited effort where, for example, they're holding themselves back as they jump over the hurdle, which they had tripped on and injured themselves severely on. And perversely, that actually increases their risk of re-injury, not that they consciously realize that, but obviously there's going to be a negative impact on performance there too. Let's look at eating disorders. Oh, so painfully common in my practice and the practice of really most sports psychiatrists. The prevalence across the board, really big range depending on the study you look at and the type of sports studied, but 6 to 45% in females, 0 to 19% in males. Elite athletes even more commonly meet criteria for disordered eating than for a full-blown DSM-5 diagnosable or ICD diagnosable eating disorder. So clinically and research-wise, we really do have to dig further into, okay, even if you don't have the requisite frequency of binge purge per week or per month, are you doing those kinds of things occasionally in a way that's a red flag for potential ultimate development of an eating disorder? And in fact, we do know something about risk factors for eating disorders in elite and all athletes. So weight-sensitive sports, big risks. So those with weight classes like rowing and wrestling, those that may be aesthetically judged, such as gymnastics, swimming, and diving, and gravitational sports in which lower body fat may be advantageous, such as distance running, cycling, or swimming. If your sport has team weigh-ins, if there's sport-specific training before the body's fully mature, so an athlete is pegged as a gymnast, and their family puts tons of time, effort, resources, money into their development as a gymnast, and then lo and behold, they go through puberty and they don't have the body type conducive to participation in that sport anymore. There can be a sense and a pressure that they have to do whatever it takes to maintain the required body type, and unsurprisingly, then eating disorders can emerge. Performance pressure and injuries are other risk factors. Moving on to attention deficit hyperactivity disorder, a focus of Dr. Doug Han from South Korea in this review from June 2019. And what we found is that ADHD may in fact be more common than in the general population when you look at athletes, since individuals with ADHD may be drawn to sport due to the positive reinforcing effects of physical activity. Now, we need hugely more research in this area. These are preliminary findings. Importantly, sport-related hyperactivity, which is normal, normative, expected in so many athletes, should be distinguished from diagnosable ADHD, because we surely don't want to be in the business of over-pathologizing behaviors that are normal and helpful and adaptive in athletes. Here's an interesting research thread, and that's the association between ADHD and concussion, with some suggestion that ADHD may be associated with prolonged recovery following sport-related concussion. Perhaps that makes sense. Some of the symptoms of ADHD look an awful lot like the cognitive clouding you see after a concussion, but we don't know the details of that interaction and if in fact it's real. Bipolar and psychotic disorders, an area headed up by Dr. Alan Curry, a psychiatrist in UK, talk about areas understudied in high-level athletes. If any of you can contribute to the world's literature on this topic, that would be most welcome. They have not been thoroughly studied, though there have been prominent cases, such as Susie Favor Hamilton, a well-known Olympic distance runner, that have been reported. But we simply don't know the prevalence. Importantly, though, both disorders show a peak age of onset coincident with the usual age of peak sporting performance, so any of us working, practicing, or researching in the field do need to be aware of this potential. It's complicated to make this diagnosis because substances that may be used by athletes, such as stimulants, cannabinoids, glucocorticoids, can cause or perpetuate mood or psychotic symptoms. So we really have to figure out, is this a primary bipolar or psychotic disorder? Is it substance-induced? And then there's this really fascinating line of research. Please do look at studying this further as well. We need more data on the fact that anything that's really antidepressant can perpetuate mania in someone who has bipolar disorder. We know vigorous exercise is powerfully antidepressant. And so there's starting to be some threads of research that show that vigorous exercise may exacerbate mania in patients who have bipolar disorder. And so what does that mean for athletes with bipolar disorder? I mean, how does that supercharge their life and their involvement in sport? And how does their involvement in sport mean that they're at even greater risk for destabilization of their mood just because of all the intense exercise in which they do participate? Moving on to sport-related concussion. So just a word on this because I'd be remiss if I didn't include it. And suffice it to say that changes in mood, emotions, and behavior are quite common following sport-related concussion. If you look at the SCAT-5, screenshotted here, the symptoms listed very clearly overlap with those attributable to anxiety and depression. So things like irritability, sadness, nervous or anxious, trouble falling asleep. I feel like I'm reading the criteria for generalized anxiety disorder or major depressive disorder. So concussion is a neuropsychiatric syndrome. It has to be on our radars. Substance use and use disorder is obviously a huge topic covered by Dave McDuff, spans ergogenic performance-enhancing substances all the way to recreational. And what we know is that the substances may be used for a variety of purposes: social, recreational, self-treatment to boost performance. The most commonly used substances in elite athletes are alcohol, cannabis, nicotine, and prescribed opioids and stimulants. But fortunately, athletes use all of those at lower rates than non-athletes in general. In contrast, athletes appear to use or misuse binge alcohol specifically, oral tobacco specifically, non-prescription opioids, and androgenic anabolic steroids at greater levels than non-athletes, and especially that's the case in power and collision sports. Gambling disorder, the hidden addiction I alluded to at the outset, a topic covered by perhaps the world's foremost expert on it when it comes to athletes, Jeff Derevensky in Canada. What we know is, even in the U.S. collegiate sports system where there are specific prohibitions against gambling, as you can see by the screenshotted ad here, it happens up to 4% of the time. When you look at professional athletes where there aren't those prohibitions necessarily, up to 57% report participating in gambling during the past year, with over 8% saying it was a problem for me. Another behavioral addiction, if you will, not necessarily an official DSM-5 diagnosis, is exercise addiction. It's increasingly well described, and obviously for intuitive reasons can be difficult to sort out when this is a problem in an athlete versus when they're just engaging in normative, expected high levels of activity. Really, where it becomes a problem are when you see things that are analogous to the criteria used to diagnose substance use disorders. So the athlete needs more and more exercise, to perceive the same benefit from it or to satisfy their cravings from it. Severe withdrawal symptoms, if you will, if they can't exercise. They keep exercising even though they're horribly injured, etc. So with that whirlwind tour, let me offer some concluding statements. Elite athletes suffer from mental health symptoms and disorders just as anyone else, though with nuanced epidemiology unique to this population. The IOC has truly committed, I believe this, to improve the mental health of elite athletes, and mental health is an integral dimension of elite athlete well-being and performance and cannot or should not be separated from physical health. With that, I thank you so much for your time and attention, and I wish you a good day.